It's 1983, and my mentor in biochemistry says, "You'll reach bubonic plague proportions." And I say, "What do you mean?" HIV/AIDS. The following year, I entered medical school. 95% of people who were HIV positive died. Now 95% are alive in 5 years. Wow. HIV is a retrovirus infecting CD4 cells or T helper cells, and the CD4 rate drops from normal about 600 to 1,000 a year to a rate of about 50 to 100 a year if left untreated. It takes a minimum 5 to 10 years before there are clinical manifestations of HIV. It's not HIV itself that leads to death, it's the low T cell count that damages your immune system. CD means a cluster of differentiation. It's like a zip code inside your T cells. Here's a picture of the life cycle of HIV from the time of infection through the time of budding off and reverse transcriptase into the protease to developing new viruses which bud off and infect the next cell. HIV is transmitted by injection drug use, which is highly efficient at transmitting. It's very common. If you share needles, you get HIV, but sex, particularly men who have sex with men, is common because the unfortunate problem about the modern HIV person is that now that you know that it's not a deadly disease anymore, the problem is you don't protect yourself as much as you used to. Transfusions basically ceased to exist since 1985 because the risk of transmission is now less than 1 in a million with transfusion. Perinatal transmission with the medications is under 1%, and needle stick injury is rare, and when it occurs, about 1 in every 300. HIV just doesn't transmit with routine contact, including kissing. Kissing is just not proven to transmit HIV. Based on the mode of transmission, vaginal transmission is extraordinarily uncommon. 1 in 3,000 unprotected episodes. With protection, it's 90% reduced even from that. So it goes to show you that you've got to have an awful lot of contact to have vaginal transmission. With oral sex, the rates are virtually incalculable. In other words, it's extremely low in terms of oral sex. That doesn't mean it's safe, it just means it's so low it's very hard for it to even be able to determine. That's what unclear means. It means virtually non-measurable. Needle stick injury is 1 in 300. Again, all of these figures are the figures without prophylaxis. Anal receptive intercourse is 1% per shot, so therefore that's extremely dangerous behavior. And mother to child, it depends. Remember, 25 to 30% is the figure without any medication. That's very important to understand. It's without medication is 25 to 30%. Most of the opportunistic infections will occur under 50 CD4 cells. Now, pneumocystis will occur under 200 CD4 cells, and there are a few things that do occur above 200 cells. Now, they're not necessarily the most fatal of the opportunistic infections. They are things that could occur in a normal person, an HIV negative person. They're just more frequent in a person with HIV. Above 200 T cells, you could find shingles, herpes simplex, tuberculosis, because it's T cells that are what fight against tuberculosis. And in HIV, if the T cells are damaged, then you have a greater risk and a greater severity of tuberculosis, oral and vaginal candidiasis, and bacterial pneumonia. And at this point, one of the most common opportunistic infections is recurrent bacterial pneumonia. To diagnose HIV itself, we have to get a first test, and that first test is unquestionably the ELISA. Now, you'll notice that the letters are all capitals. That's because it's an acronym for enzyme-linked immunosorbent assay, or ELISA testing. ELISA testing, by definition, is always an extremely sensitive test. And a very sensitive test means there's almost no false negatives, because we want a test that we're sure that with its negative, it is truly negative with 99.999 sensitivity. How good does that get? This is confirmed with the Western blot. Now, the Western blot means you're actually measuring the genetic elements of the HIV virus. You're not measuring the body's reaction to it, but the actual virus itself, viral particles in their genetic material. For infected infants, you can't use the ELISA test because in an infant, you're measuring the antibody passed through the placenta from the mother. The same way a baby is covered for vaccinations for the first 6 months by mom lending immunoglobulin across her placenta. In the same way, the baby will carry the mother's IgG antibodies and make a false positive ELISA test. So for infants, we do PCR and viral culture. Viral culture is only the most accurate test to diagnose it in an infected baby. ELISA testing is unreliable in those infants because of the maternal HIV antibodies being present for up to 6 months after delivery. A patient is started on antiretroviral medication. What would you test first to look for a response to therapy? The answer is PCR RNA viral load. A patient goes on medications and they are resistant to the medications. Which of them goes up first? HIV, PCR, viral load. So viral load testing is the first thing that changes to measure a response to therapy. Decreasing levels are good, and it detects treatment failure. Rising levels are bad, and it diagnoses the HIV in babies. But it is always the first thing to change to indicate either success or failure. A patient can die of HIV if the viral load becomes undetectable. Now, this is why the goal of therapy is to drive down the viral load, and undetectable levels at under 50 or even under 20 on some of the assays means that the T cell count is going to rise. Because when you get rid of the viral load, it means that the HIV is not in sufficient amounts to be able to kill T cells. HIV goes and hops, literally hops from T cell to eradicate them and kill them. So if you get that viral load to undetectable amounts, it's like eliminating criminals in the body. There's nothing around to assault the T cells. When the T cell count rises, the opportunistic infections stop. Period. That's it. Now, when HIV medications such as the protease inhibitors were first developed, we weren't sure whether those T cells were really good. Because like, wow, they're rising, but maybe they're like defective. And what we know now is that they rise, and whether they're defective or not, we know that they're good enough to stop the opportunistic infections. They may not be normal, but they work. Life expectancy when the viral load is undetectable by PCR RNA is the same. It's equal in duration to an HIV negative person. Wow. Life expectancy when the viral load is undetectable is equal to an HIV negative person. That's amazing, really. Well, since I've now built up the issue of using antiretrovirals to get rid of viral load, get rid of the circulating HIV virus, which will lead to a rise in T cells, how do I make sure that I'm going to get rid of that viral load with the medications I'm using? Well, HIV is one of the only things where we don't actually have to grow the virus itself and culture to tell what it's going to be sensitive or resistant to. We actually know so well what genetic mutations there are that correlate with sensitivity that if we do resistance testing, as it's called, genotyping, we perform this prior to initiating antiretroviral medications. And this decreases the likelihood of starting medication to which a patient's virus is resistant. Now, resistance testing evaluates treatment failure. If a person goes on medication and they have an initial drop in the viral load, but then why does it start rising? Oh my God, what's happened? Well, genotyping will tell us what we can switch them to. It guides the choice of medications. We select 3 drugs from 2 different classes to which the genotype says, hey, this person's susceptible. And if you use multiple medications from different classes to which the virus is susceptible, it's gonna go away. But this is really extraordinary to say that instead of waiting for the virus to grow up, we actually can instantaneously, on a single test, say, no, 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 you don't even have to wait for it to grow. We know that this mutation, this genetic type, makes it sensitive to those drugs. Or, no, 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 avoid that drug because this mutation means that that person's virus is resistant to a drug. That's pretty cool. For HIV, treatment's initiated when the T cell count goes under 500, or when the viral load is very high, above 100,000, or for sure when opportunistic infections occur. Now, this question about when to start is not asked too much. The reason is that it changes, it moves. 15 years ago, we used to say start under 500, then it went to 350. Now it's back up at 500. So we tend to emphasize what are the opportunistic infections and what are the adverse effects of the medications, because adverse effects don't change. They don't change. They're more permanent. And at this point, HIV has become a real subspecialist disease. So consequently, the most important thing is to say, okay, they're under 500, their viral load is high, they got started on medications. Okay, now what are the adverse effects of the medication that the subspecialist chose? Now, after we start therapy, treatment failure first manifests with a PCR RNA viral load, and that is because viral load is incredibly fast. If you skip your HIV medications for just a day or two, your viral load starts to rise. And when you start medication, the viral load will actually start to decrease in as little as 6 hours. Wow. What's the best initial therapy? Well, that answer is very easy because M-tricytidine, tenofovir, and efavirenz, all three of these medications are used in one single combination tablet. And not only is it the easiest thing to take, it starts out with number one, efficacy. So the three of these together is in one combination so that it has the greatest efficacy and lowers the viral load and raises the T cell the most. You do not have to learn the amount of milligrams for each of them because unnecessary, we don't test you on that. You start first with these simply because if you take 1,000 patients and put half on this combination and half on another combination, this is the combination that lowers the viral load and raises the T cell count the most. If a patient is started on antiretrovirals and the viral load goes undetectable and the T cells rise, that person's simply not going to die of their HIV. Period. Thank you. End of story. Finished. So if the treatment is failing, the first thing that we use to detect that is that the viral load will rise. If the viral load rises, this is going to be followed by a T cell count drop, or it's simply not going to go up at the beginning. If the T cell count drops or fails to rise, then the person's going to get opportunistic infections, and then they're going to die. So the T cell counts are slower than changes in viral load because the viral load changes are what lead to alterations in T cells. The virus jumps from T cell to T cell. If you get rid of the viral load, it can't go to the T cells and kill them. So the alternative drug regimen is that if M-tricytidine, tenofovir, and efavirenz can't be used because of resistance, alternate treatments are based on combining 3 drugs from 2 different classes. This is indispensable as a principle because if you add or toss on one single drug to a failing collection of medications, it's not going to work. It's not going to be able to control them. The different antiretrovirals are broken up by class. The first class, the primordial HIV medication approved in 1989, was zidovudine, sometimes called AZT. Now, the vudine ending is not around too much anymore. Those drugs are older and a discontinued ending. But we have dadanazine and stavudine and lamivudine. Now, the vudines are nucleosides. Basically, what they do is they take a virus that has attacked the T cell. The T cell has DNA in it to replicate itself, but the virus is RNA. So in order for the virus to kill the T cell, it has to inject its RNA genetic material into the T cell. It has to be transcribed from RNA into DNA, and then the new DNA gets inserted into the genetics of the T cell and actually programs the T cell to make more virus. So these medications stop the transcription of the viral RNA into DNA. Now, that's called transcriptase. Now, since the usual transcriptase is to take DNA and convert it into RNA, so the RNA makes protein, this is a reverse transcriptase. In other words, RNA going backwards into DNA is reverse transcriptase. And this basically stops it. It basically stops the genetic reproduction of the virus. Now, the drugs are essentially interchangeable. Emtricitabine, abacavir, and tenofovir. You can't say one is necessarily better than the other. They're all about equal. The most important thing is that you have to use more than one of them, and it has to be combined with a different class. Now, the adverse effects are indispensable for you to learn. It is indispensable that you know that zidovudine causes macrocytic anemia, and didanosine and stavudine cause neuropathy and pancreatitis. Lamivudine kills hepatitis B. Abacavir is associated with a very, very severe hypersensitivity reaction. Tenofovir has some renal toxicity. The next class is the non-nucleoside reverse transcriptase inhibitors. Now, the ultimate mechanism is the same. It stops the reproduction of the RNA so that it can't be injected into the T cell's genetic elements. It's just a different molecule, so it's a non-nucleoside. Efavirenz is by far the best of those. Etravirine and nevirapine are alternatives. The protease inhibitor class stop the budding of the virus off so that it can't spread to others, can't spread to other T cells. The protease inhibitors are ritonavir. You notice that ending is very similar. Sequinavir, nelfinavir, imprenavir, fosamprenavir, lopinavir. Well, the avirs in this class all mean AIDS virus drugs. As a class, they cause lipid and glucose problems, hyperlipidemia and hyperglycemia. But since they're so efficacious, it's better to be alive with hyperlipidemia than dead with a normal LDL. Now, atazanavir, indinavir is critical because it causes kidney stones. It's about the only use of it is shows up on board exams to make sure you know that it causes kidney stones. Indinavir was the first of them that was approved. We don't use it now because of dosing issues and because of the stone problem. Topranavir and darunavir. Yes, you gotta know them. Yes, they save lives, and yes, I know it's annoying to learn the names of all these medications, and gosh, isn't it horrible when people's life-saving medications that can transform the whole world is an inconvenience to medical students? Wow, tough. Learn them. These medications are used with drug resistance. People have resistance to multiple classes of first-line agents. I have them on a separate slide for a very particular reason, which is they're not used first. They are basically salvage drugs. Entry inhibitors means that when the HIV attaches to your T cell, the HIV needs an enzyme to allow it to enter into the T cell. So before you can have reverse transcriptase, you got to be able to enter the cell. You got to be able to land and inject, sort of like watching the elevator door open before you can get into a building. So the entry inhibitors is enfuvirtide and maraviroc. Well, we know that 2 to 3% of the population is resistant to HIV. Isn't that amazing? In other words, 1 out of every 50 people just can't get AIDS. That's because they're defective or mutated. They're chemokine receptor 5, the receptor for which HIV attaches to. So we have the bright idea that if you have a medication that will inhibit chemokine receptor 5, you can stop HIV. And that's what these drugs do. If you can stop chemokine receptor 5, you don't get infected with the HIV. Now, as a medication, as a single agent, they won't work. But they will work when used in combination with other drugs. Integrase means that the HIV is attached, and entered. It has been transcribed, reverse transcribed from RNA to DNA. Now, in order for that newly transcribed DNA to enter into the T cell's genetic material, it has to be integrated. It has to be integrated inside the DNA of the T cell. And that integrase can be stopped with raltegravir. Now, you might say, well, how come we can't just use one drug? And that's because the HIV virus is amazingly adaptive. So we can't just use one of any. And step 2 is just not going to require you to know the differences in efficacy between the classes because no one really knows. All significant needle stick injuries, sexual exposures, bites that break the skin need basically 4 weeks of combination therapy. Exposures to urine and stool are not an indication for prophylaxis because urine and stool just doesn't normally contain blood or white cells. Fundamentally, you have to be exposed to blood, white cells, or sexual fluids, and that's largely because sexual fluids, vaginal fluids, and seminal fluids have some degree of white cells. Post-exposure prophylaxis isn't routinely indicated for a needle stick injury if the HIV status of the needle is unknown, and that's because HIV just doesn't live long in needles. So if you see a case where it describes a needle is found in the bedding or linen of a patient who's left, or in a pile of clothes or towels and stuck by accident, then the rate of transmission is so low also because HIV doesn't live in the needle very long. A needle from yesterday won't transmit today because the virus can't live in a dry surface. It would die off. So since the risk of transmission is so slow, so low, we don't use the prophylaxis unless we know you stuck yourself on a fresh needle. Fresh meaning instantly, like a needle just in HIV blood minutes ago, and we know it's an HIV positive person. Zidovudine is a medication that can cause a macrocytic anemia, and that's not megaloblastic. Megaloblastic means hypersegmented neutrophils, so we don't see hypersegmented neutrophils, but we will see a high MCV. Stavudine and didanosine cause peripheral neuropathy and pancreatitis. Unclear reasons, but they have the identical adverse effects. Abacavir has a tremendous hypersensitivity and Stevens-Johnson reaction. And if a person has a hypersensitivity to abacavir and it gets used again, it can be fatal. Protease inhibitors as a class, every drug in the class causes hyperlipidemia and hyperglycemia. It is not dangerous. It's not such that it will cause a fatal DKA, but they raise sugars. Indinavir will cause kidney stones in 4% of the people who use it. Tenofovir causes renal insufficiency, particularly tubular problems. Pregnant patients represent a unique area of HIV therapy, and that's because everybody who's pregnant needs to be on antiretrovirals. Now, if a person is already on antiretrovirals, you simply continue what they're already on. What about the people who are pregnant and are not on antiretrovirals because they only found out that they're HIV positive because of mandatory offering of HIV testing during the pregnancy? Well, this is the unique part. All pregnant patients who are HIV positive need to be on medications. If the T cell count is high, then after delivery, you can stop them. But during the pregnancy, you start combination antiretrovirals. This is to make sure that there's very little transmission of HIV. If you're on antiretrovirals during pregnancy and you get that viral load down and T cell count up, antiretrovirals with controlled virus result in a transmission rate of 1% or less. Wow. And not only is it effective, the only one of the HIV medications, remember that really long list, that's potentially teratogenic is efavirenz. And even that is only proven in animals, not in humans. In humans, there is no proven human teratogenicity of any one of these medications. Wow. After delivery for the mother, if her T cells are high and she doesn't need them for herself, after delivery and the baby's out, you can stop those medications. This is the only point of difference between a pregnant woman and a non pregnant woman. In a non pregnant woman, you wouldn't start at all. You have really high T cells, low viral load, don't use them all. But during pregnancy, we want to prevent the perinatal transmission. So at any T cell count, any viral load, an HIV positive person needs to be on antiretrovirals during the pregnancy. If the T cell count is low or the viral load is high and the person has delivered, you continue those medications because she needs them for herself. For Mr. Baby, use zidovudine during delivery, like intrapartum IV AZT. And after delivery, use it for 6 weeks to help prevent transmission. Now, this is in people who we don't even know whether they're HIV positive. This is for the babies, and even if you don't even know they're HIV positive, use it as a kind of a post-exposure prophylaxis for the baby. If the baby is actually HIV positive, which is rare now, very rare, a truly HIV positive baby, the one that is not just carrying mommy's antibody, is under 1%. So if the baby or the child is truly HIV positive themselves, they'd get 2 nucleosides in a protease inhibitor or 2 nucleosides in a efavirenz, just like everybody else. But simply as post-exposure to the mother's vaginal fluids, use zidovudine intrapartum and for 6 weeks after to help prevent transmission. Summarizing the care of an HIV positive woman during pregnancy, if she's on antiretrovirals at the time of the pregnancy, simply continue the same medication, except we'd prefer to switch efavirenz to a protease inhibitor because efavirenz is potentially teratogenic. Now, I mean prefer because if you were presented a case where it said that the only one of the non-nucleosides or protease inhibitors she was sensitive to was efavirenz, then in order to protect the baby and the mother, then you would use efavirenz because efficacy beats adverse effects. But we in general would prefer to switch efavirenz to a protease inhibitor. If she's not on antiretrovirals and the T cell count is low or the viral load is high, in other words, she's not doing really well, then you start the medications right away and continue after delivery. Now, if it's the other way around, she's not on antiretrovirals, but her T cell count and viral load is, T cell count is high and the viral load is low, then you start the retrovirals now. But if the woman doesn't need them for herself because the T cell count is high, the viral load is low, you can stop them after delivery. Cesarean section in the HIV positive woman is a special consideration because we have a special number for cutoff of what we consider to be controlled. The cesarean section is not done in all HIV positive mothers. It's not, because if the viral load is low, you don't have to. You should get intrapartum zidovudine for every pregnant woman, but a fully controlled HIV meaning a viral load undetectable, has less than 1% transmission. So why do C-sections in everybody? You don't need to. What do we mean by fully controlled? It means you got that HIV viral load down to under 1,000.